Okay, now.
Okay, that's awesome.
Very good evening to all my dear viewers who have joined here through this wonderful session again. Today we are going to have a case discussion on cerebral palsy. We have Dr. Madhumita, final year MBBS student from Chettinad Medical College, here to present a case on cerebral palsy. I thank Dr. Prithiviraj sir once again for joining with us today in spite of his schedule, and he will be here to guide us today. Thank you so much, sir, and I will hand over the session to you, sir.
Okay. Good evening to one and all present here. So today from this, we will be starting the case clinical discussion in the pediatrics. So we will start with a very toughest case in the for UG for undergraduate student, which is cerebral palsy. In most of our university, like in Tamil Nadu's university, one of the major case, which is the major case that is given to all undergraduate student, will be the cerebral palsy. So we will going to discuss uh, from the basics, from history taking and general examination, physical examination, which is very consistent to the CP, and how to delineate from the history itself whether this could be a CP or any mimics of CP. So we are having a so we will start discussing the case, and I welcome the final year student Dr. Madhumita Ganesh from Chettinad Medical College, who is going to present our case. So I am handing over the mic to Madhumita Ganesh. Okay, ma, you can start the case.
Yes, sir.
Sure.
Thank you, sir. Good evening to one and all present here. I am Madhumita Ganesh of Chettinad Hospital and Research Institute, here to present a case on cerebral palsy. So cerebral palsy, it is refers to a permanent and non-progressive, occasionally evolving disorders of tone, movement, and posture caused by an insult to the developing brain. So we'll start with the case presentation. A 4-year-old male child, Abu Hussein, first born out of a third-degree consanguineous marriage, coming from Red Hills, whose informant is his mother with fair reliability, came to Chettinad Hospital for review for the delayed developmental milestones noticed since 6 months of age. So, history of presenting illness. His mother noticed delayed developmental milestones since 6 months of age. Since there is developmental delay and on direct questioning, there is an obvious postnatal insult, I would like to analyze history from antenatal history. So, over here, there is a significant perinatal history. We can say that first in history than the developmental history. So in my case, there is a significant perinatal history. So I'm going to go ahead with that. So birth history, married life is for 5 years. Mother's age at time of pregnancy is 27 years. Father's age at time of pregnancy is 29 years. And it is a third degree consanguineous marriage. Preconceptional folic acid is not taken. So we normally take preconceptional folic acid for 4 weeks prior to conception. The pregnancy is booked and immunized. She has had 4 antenatal visits, and her weight gain during pregnancy is 9 kgs. So here a Viva question can be that what is the normal weight gain during pregnancy, and that is around 8 to 12 kgs or 9 to 11 kgs. So first trimester history, pregnancy is confirmed by UPT, booked and immunized, folic acid tablets were taken. There is no history of radiation exposure. So over here, the permissible upper limit of radiation permissible for pregnant women is less than 500 millirads, and an X-ray emits about 100 millirads. There is no history of fever with rashes. This is asked to rule out any torch infections. There is no history of maternal hypothyroidism. Dating scan and NT scan is done. It is done around 10 weeks. Moving on to second trimester, quickening felt at 20 weeks. Iron and folic acid tablets were taken. So this is to rule out any neural tube defects. Anomaly scan was done at 20 weeks, which is normal. OGCT done, that is an oral glucose challenge test, that is also normal. There is no history of headache, blurring of vision, and pedal edema. This is asked to rule out any placenta previa or any hypertension. No history of leaking per vaginum or bleeding per vaginum. Third trimester history, she continued to perceive fetal movements. There is no history of headache, blurring of vision, pedal edema. There is no history of leaking per vaginum or bleeding per vaginum. There is no history of fever or UTI. Over here, again in third trimester, we ask about the history of fever because if the mother has fever during the third trimester or during pregnancy, it can cause an increase in interleukin 6 levels in the fetus, and that increases the pro inflammatory cytokines, which can also lead to delayed developmental milestones. So, with regard to cerebral palsy, in our obstetric history, we can also ask about alcohol, smoking, and drug intake. Alcohol can lead to microcephaly, which is associated with delayed developmental milestones. Smoking is associated with intrauterine growth restriction, which can also lead to delayed milestones. And over here, we need to rule out there's a difference between regression of developmental milestones and delayed developmental milestones. Delayed developmental milestones, you do not lose the developmental milestone that is already achieved. But in regression of developmental milestones, we lose the developmental milestone that is already achieved. This can be seen, for example, in early onset. In infancy, it can be seen in Gaucher type 2 Niemann-Pick disease, and during like 1 to 2 years, we can see it with homocystinuria. More than 2 years, we can see it in adrenoleukodystrophy. So, can I move on to postnatal history?
Okay, well, after completing postnatal history, you stop. So we will discuss some points regarding how to differentiate. You very well. You told much more things, and with that, we will just sharpen some things so that it will be easy for the people who are seeing this. Okay. After
Yes, sir.
postnatal history, you stop. We will discuss from the beginning. Okay. Cool.
All right. So,
Hmm.
third trimester, we have discussed fever and UTI, which
Yeah.
wasn't present. So, growth
Hmm.
scan taken at 33 weeks was normal. There's a history of bike accident in the 9th month, which the mother has informed us about. Natal history, it is a full term LSCS. There is non progression of labor. So, over here, a Viva question can be such that what is exactly a prolonged labor? More than 18 hours is a prolonged labor in a primigravida, and more than 12 hours is a prolonged labor in a multigravida. So, this time interval, that is the 18 hours and the 12 hours, it is between the first and the second stage of labor. So, moving on to natal history. So, full term LSCS, non progression of labor, and the baby did not cry immediately. So, this can be a sign of birth asphyxia. 2.5 kg is the birth weight. So, over here, I have the grading of HIE. That is the hypoxic ischemic encephalopathy. It is a SARNET and SARNET classification,
Very good.
which is classified into grade mild, which is 1, moderate, which is 2, and severe, which is 3. And it can be based on the level of consciousness, muscle tone, complex reflexes such as the sucking reflex or the Moro reflex, and seizures. So I'll move on to postnatal history.
You can go for
The baby was intubated. Yeah, okay. The baby was intubated in the labor room and shifted to NICU at birth. The mother was not aware about the intubation, so we had to ask the faculty over there. There is 5 days of NICU. There is history of seizures. So over here, a Viva question can be such that is febrile seizures normal? Febrile seizures is normal from 6 months of age to 5 years of age. And seizures, they can also be a question that what is the causes of day 2 convulsions? It can be metabolic causes such as hypoglycemia and hypocalcemia. There is no history of jaundice. Breastfeeding is started after 2 hours of delivery, but it is normally advised to start breastfeeding after 1 hour of giving birth through LSAS. Breastfeeding is continued till 6th month, and 7th month the weaning has started. Advised to continue anticonvulsant and follow up. At 6th month of age, the mother felt that all limbs were stiff when changing clothes and grooming.
Okay, so we'll stop here. Okay,
Yes,
you
sir.
start. Okay, you come from the beginning. You bring the slide to the beginning. So we'll see.
Yes.
To be honest, you presented very well, ma. I never expected that some final year student can present in this way. The way you presented, way you wrote is it's very nice, and I guess if you present in this way, you can get a gold medal in your exam. Okay, so we will start with since you started with the cerebral palsy itself, but to be honest, in your examination, you cannot say that first. So whenever you are presenting a case in anywhere, just start with history. Don't say it's a case of cerebral palsy. So no one
Yes,
should
sir.
know that you are presenting a cerebral palsy. Okay. Okay.
Yes, sir.
So now you said it's a 4-year-old male child. Okay. Who's born out of so now you can see, tell me with the CP per se the cerebral palsy. What is the gender predilection for a cerebral palsy?
Males are more
Is it-
affected than females in cerebral
Very
palsy.
good. Yeah, really. That's the very good answer. Yeah, males are more commonly affected than female. And do you know the ratio?
I'm not really aware of the ratio. Sorry, sir.
Okay, no problem. At least you answered it. Yeah, this is the one thing is male are more commonly affected than female. The ratio is 1.4 is to 1. So it's the ratio is 1.4 is to 1. And second thing is estimate of birth weight. Like birth weight, if the child is low birth weight, as well as that if according to the growth chart, if the child falls below third centile, and or else if the child is large for gestational age. That is, if according to the growth chart, if he or she falls above 19th percentile, they are also prone for cerebral palsy. And as per your Nelson 21st edition, it has been given that is for a low birth weight, that is LBW or SGH, small for gestation age, the risk is 16 times than a normal counterpart. Whereas when compared to LGA and normal counterpart, it is 4 times higher risk of developing cerebral palsy compared to the normal counterpart. Right?
Yes, sir.
So this is one of the question they can ask. My male child has more predilection for developing cerebral palsy. Now, tell me what is a consanguinity? What is the importance of consanguinity in a neurodevelopmental case? That is neurodevelopment. I'm not taking it's a cerebral palsy. It could be a neuro regression or it's a global developmental delay. It could be anything. So we are not taking per se as a CP. If it's a case of neuroregression or neurodevelopmental delay, what's the role of asking consanguineous marriage? And what are the types of consanguinity is seen? You have
Consanguinity, it's there's 3 degrees. First degree
very
is
good.
siblings.
Mm.
Second degree
Mm-hmm.
is the
Mm-hmm.
um basically the uncle. I think I'm not sure.
Yeah, yeah,
And
yeah, yeah, yeah.
yeah,
The uncle,
the
mane, if it, yeah, it's mother's brother or father's sister. Mane,
okay.
maternal uncle, and paternal aunt. If their child marries their paternal aunt or maternal uncle, it goes for a second degree. And third degree,
Third degree is cousins.
yeah, cousins. So in India, which degree is more common?
In India, third degree is more common.
Yeah, yeah, third degree. Yes, third degree is more common. So here also we have a third degree consanguineous marriage. So now tell me, what is the consanguinity? What is the relation of consanguinity with any neurodevelopmental case?
Consanguinity is a known risk factor for genetic disorders. So
Very good. Mm-hmm.
autosomal recessive
Yes,
disorders and
yes.
inherited disorders can be transmitted to the offspring.
Whatever you say, Gotch's disease, Niemann-Pick disease. So they are enzyme-related disorder, and most of them are autosomal recessive. And this autosomal recessive are mostly seen in consanguinous, that is third-degree consanguinous. So,
Yes, sir.
so any consanguinous has an important role to tell any neurodevelopment if that's a consanguinous marriage. So you can go that could be any component of genetic and metabolic cause in this neurodevelopmental regression or neurodevelopmental case. Okay, that. So
Yes,
that
sir.
is you tell about the location, and now the child presented to your hospital with delayed developmental milestone, which was noticed by mother 6 months of age. Okay.
Yes, sir.
So most common presentation of any neurodevelopmental case would be, as you said, this word delayed developmental milestone. And for CP, it is more commonly a delayed developmental milestone is the most common presentation because mother says at 1 year of child, the mother will be telling that my child is not doing the same thing which my elder son did, or like that, or the child is not doing same like other people who are of his same peer group. So this is the most common complaint with which the mother takes the child to the hospital. Okay.
Yes.
Now, which developmental milestone you will be more commonly affected in CP?
The gross motor developmental milestone will be affected in cerebral palsy.
What is the reason?
Gross motor developmental milestone, sir.
Yeah, yeah. Well, why? I am asking why. Why the motor is more affected?
Not sure, sir.
Okay, simple. In any insult, it is static encephalopathy. Cerebral palsy is nothing but a permanent motor disturbances because that's a static encephalopathy to developing brain. Because of this insult, it affects your white tracts. So whenever there's a white tract involvement is more affected, so that's the reason because white tracts are which is receiving all the signals from your periphery to the brain, and at the same time the brain will also send the impulse from the cortex to the periphery. As a result, this tract is more involved in the cerebral palsy. So motor involvement is more commonly noted in CP rather than your sensory. Yeah, sensory is also seen, but it's very less likely. That's the definition, as you say, the definition, which is nothing but a permanent static motor disorder, which involves both your um, which involves both the posture and tone because of the insult that occurs either antenatal, during natal, or postnatal to the developing brain. So this is just a concise definition for the CP. So that's the reason why your motor milestone is more affected rather than the other milestone. But other milestone may get affected because of other comorbidity. It's not that other milestone will not get affected, but most commonly your motor milestone is get affected, right?
Yes, sir.
Okay, next to the next, you can slide it down. Okay, okay. So you said this is one of the important thing which you highlighted. Whenever you find a case of any neurodevelopmental delay, and if you are sure that the insult is because of any trauma or any thing that happened during birth or even before birth, then you have to start the history from the birth. So this is one thing which you started. I guess that for every student who are presenting any case regarding the CP, if you are confident enough that the history has to start from birth because there was an insult, as per your history there was an insult, then you can start from the birth history. The examiner will become very perplexed when you start in this way because they know that you know the concept. So this is one of the tactics you should know. Any CP child always start from birth history. After history of presenting English, start from birth history because most of the time 80% of common risk factor for CP or any neurodevelopmental state is because of antenatal history. So antenatal risk factors are the most common cause of cerebral palsy. So always start from birth history, right? So you started it very well. So birth history, you said it is an first order child, right? First order
Yes, sir.
child and third degree consanguineous marriage. Already we discussed about a consanguinity. Now, what is the importance of preconceptional folic acid in this case? For any neurodevelopmental case?
Preconception.
Yeah, sure.
Preconceptional folic acid, because many people do not plan their pregnancy, it is
Mm-hmm.
better to take preconceptional folic acid 4 weeks prior to conception, so we can prevent neural tube defects.
Very good. Now I am giving a question. If it's what is the normal range of what is the dose you advise for a for priming who has come, not a priming. For example, young married couple come to your clinic and they are saying that they are planning for pregnancy. And now you have to advise pre-pregnancy folic acid, preconceptional folic acid. What is the normal dosage you will advise for a first child? For the first one, now they have become first pregnancy.
400 to 600 micrograms.
Yeah, very good. 400 micrograms. No, it's simple, well, simple. So for your easy memory, you can take it 400 microgram. Okay. Now you have another couple who had a coming for their second pregnancy with an history of meningomyelocele in their first child, and the child has been operated, and the child is now LT and 5 years and having a good score and is going to LKG. Now they have came here for the periconceptional counseling. Now, for this, since there is an history of meningomyelocele, that's an open neural tube defect, what is the dosage of folic acid you will advise for them?
For a child with previous neural tube defects, we can
Mhm.
suggest 5 milligrams of folic acid.
Very good. 4 to 5 milligrams. So this is the Viva question they can ask. Folic acid supplementation in a first pregnancy without any prior risk, go for 400 to 600 microgram. If there was a previous pregnancy with an open neural tube defect, The second pregnancy should consume periconceptional folic acid 4 weeks, at least minimum 4 weeks. It can be even before that, with at a dose of 4 to 5 mg stat. Okay, nice. And what book and immunize? What do you mean by book? What you when you say that the case is book?
Booked pregnancy means she is registered under the hospital, and she has to
Mm-hmm.
come for a certain number of antenatal visits, at least
What
3
is the
to 4
minimum?
antenatal.
Very good. Which is
Yeah.
according to WHO, this would be a 4 minimal visit. First
Yes.
trimester, second trimester, third trimester. First trimester, how many visits? Second trimester, how many? And third trimester, how many visits?
Uh, I'm not really sure about that, sir.
Okay. So you have to, okay, it's OBG, but even in a pediatric, they can ask. First trimester, you should have a 1 visit, second trimester, 1 visit, and third trimester, minimum 2 visits. So totally 4 visits. Read it in the book of at what gestation age the mother has to visit. So this is a book. And immunized. So what is the immunization now we are following for the maternal vaccination?
We give TD vaccine between 27 weeks and 36 weeks of gestation.
Yeah, one will give in second trimester. First will give first trimester and second is second trimester. Okay, it's I guess 16 and 20 weeks. To get
Yes, sir.
just get sure shot it. Okay, so we got TD. Very good. Initially, before 3-4 years back, when I was my undergraduate student, it was TT. Now they have changed to TD. So this is the one of the question they can ask because of new change. So the mother has antenatal visit and weight gain during pregnancy. Okay. Now we go for first trimester history. Okay. So what is confirmed by UPT? So okay, what is the best way to know the gestational age in first trimester?
We can calculate from the LMP, the last menstrual period.
If it's an irregular cycle, what would be the best method?
The beta HCG is normally found in urine pregnancy test.
Yeah, ma, that's okay for UPT, it's confirmation. But I am asking for the gestational age assessment for the fetus, which method will be more accurate? Either it's based on LMP or something else. You
Is
have
it
already
screening,
given
sir?
no, ma. You have already given the
Okay.
answer in your answer here itself in your first trimester history itself. What is dating scan? Why the name is known as dating scan?
It is done to see if there's any predisposition to any syndromes and all. It's done between the 8th and the 14th week of pregnancy to see
Okay, we
the
have two.
gestational
Yeah,
age.
very good. As the dating scan is only not to the accuracy of the gestational age can be done in your first trimester dating scan, where you are going to see which parameter is used to know the accurate for gestational age in first trimester.
Yes, sir.
Which is the parameter you measure in the dating scan for estimation of gestational age?
Not sure about this, sir.
Okay, it is crown rump length, CRL. So this CRL will give an accuracy of 5 to 7 days. If you are giving a CRL which tells it is a 10-week pregnancy, as per the CRL, it either could be a 9-week or it could be 11 weeks. So the accuracy is plus or minus 5 to 7 days. It is the only accurate method when you do in the first trimester. This scan will give an accuracy of greatest accuracy of gestation age prediction rather than in a second and third trimester scan. Okay, so this is CRL is the most accurate way to estimate the gestation age of fetus in all pregnancy will be your first trimester dating scan. Okay. Okay. So folic acid tablet were taken during the first trimester, right? Now
Yes, sir.
you said there is no history of fever with rashes. So
Yes, sir.
what torch infection? Which now I will ask specifically to the CP. Which torch infection has a correlation with your cerebral palsy?
Um, Rubella can cause
Microcephaly, microcephaly is one of the important factor for CP. Without microcephaly, CP is less likely, you can say. But no, rubella may can, but it's not that much associated with your CP.
toxoplasmosis may cause.
No, it's not.
Okay.
It's your CMV, cytomegalovirus. The
Virus.
congenital cytomegalovirus is known to associated with your spastic hemiplegic type of CP. So it is more association has been found. That's why congenital CMV infection has been said to be more commonly associated with your um, spastic hemiplegic CP, right? Okay. There is no history of maternal hypothyroidism. What is the relation of maternal hypothyroidism in a neurodevelopmental case? Not in CP, neurodevelopmental case. What's the importance of maternal hypothyroidism?
Hypothyroidism is a cause of reversible mental retardation in fetus.
Very good. Exactly. This is the congenital hypothyroidism. So congenital hypothyroidism, one of the major causes is undetected maternal hypothyroidism or even detected or else the mother is not taking the tablet because during the first trimester or in the second trimester, your neural developmental is most based on your thyroid hormone. Even though 10 to 12 weeks of gestation, the child thyroid hormones start thyroid start producing T3 and T4 by 10th week of gestation. But even before that, the brain needs some thyroid hormone, right? So for that, the maternal thyroid axis should be stable. If it is not stable, or in a case of maternal hypothyroidism, who are not taking the tablet, or in not undetected subclinical maternal hypothyroidism, the child, the fetus brain development get impaired and may lead to some problem. That's the one of the reason why hypothyroidism has to be screened in any pregnancy mother, and this history has to be taken during the first trimester because your hormogenesis is mostly occurs in first trimester. And neurodevelopmental case for any neurodevelopment delay, hypothyroidism has to be ruled out. So this one of the history is very important. Okay, right. Then okay, second trimester. Okay, fetal movement. Okay, fetal movement felt at 20 weeks. Okay, now tell me what is the quickening? What's the quickening in a primary gravida and second in a second gravida, third gravida? Where the quickening is felt earlier, whether it's a primary or it's a second gravida mother.
Normally, for the first time, multigravida can feel it faster than the primigravida quickening.
Yeah, very good. Because they are already experienced it. So that's why for a second or third gravida mother, they always a month ago, like for example, you are say 20 weeks, they can even appreciate at 16 week itself. So that's the quickening. What is the importance of quickening in a neurodevelopmental case?
For example, in HIE, the quickening can be felt way later because of
Okay, hypoxic ischemic encephalopathy in utero hypoxia. You are saying in utero hypoxia, but that is less common. Apart from that, if the muscle, the mother, the child is developing other than that case, HIE, okay, it could be an example, but it is a rare, least possible cause for that. Apart from that, any other thing?
maybe any placental insufficiencies or placenta previa.
No, ma'am, that's not.
Okay.
It's a peripheral cause. You can go for peripheral, not go for central cause, peripheral cause. If the child is affected from any muscular dystrophy, myotonic dystrophy, where the muscle is involved, okay, they
Okay.
go for hypotonia. So these children, they have a delayed quickening or no quickening at all. So for any muscle disorder, for any muscular disorder cases in fetus or in a child, you have a Duchenne muscular dystrophy or myotonic dystrophic child, that will be similar. That will be clinching history that mother will tell that they didn't feel any much movement during the pregnancy. So this tells about the fetal hypotonia. That is one of the earliest sign of any myotonic dystrophy in the children, muscular disorder. Okay, that's the importance of quickening in a neurodevelopmental or say muscular disorder cases. Okay, iron and folic acid tablet. Okay, anomaly scan done at 20 weeks. Oh, okay. What is this OGCT?
OGCT is oral glucose challenge test. It is
When
done
it
to
is usually
diagnose.
there? Yeah, you tell that.
Yeah.
Yeah, you tell.
20 weeks it's done.
Okay,
20 to
even
24
now,
weeks.
it's not that it's not standard. Like it is not compulsory that you have to do in 20 weeks also because there are many mothers who have undetected GDM, undetected diabetes before pregnancy. There are many mothers who have a pre-gestational diabetes method, but they didn't have a regular follow-up or regular checkup. and they get diagnosed because at the 20 weeks. And most of the time we consider it as a GDM. But in fact, in most of the cases, it was a pre-gestation diabetes mellitus. That's the reason during the booking, when they come the first visit to a healthcare professional, that at the same time, at the booking visit itself, we go over OGCT at the first trimester itself. It's not saying most of the book, but in practice, we do add sugar glucose tolerance at the first visit itself, because there are many mothers who have not had a regular checkup before pregnancy, and that they get missed this pre-gestational diabetes mellitus. And when we do a first checkup at 20 weeks, you think it as a GDM, gestational diabetes mellitus, but actually it was not a GDM. It was a pre-gestational diabetes which was undetected. So what is the difference between pre-gestational diabetes mellitus versus gestational diabetes mellitus in view of your fetus development? What is
The
it can go for?
features can be different. In pre-gestational
Hmm.
diabetes, more congenital anomalies are common, such as
Very good. Yeah.
PSD or
Hmm.
sacral
Hmm.
agenesis. But in
Hmm.
GDM, it can be controlled in the initial stage if it's well controlled with diet, or
Hmm.
it can be controlled with insulin as well. But
Hmm.
uh, like
Yeah.
pre-gestational diabetes is most common for organogenesis malformations.
Very good. Very good. Because hyperglycemia is itself a teratogenic. It's a teratogen. When it is not controlled during the organogenesis, it leads to a condition known as diabetic embryopathy, and it affects all of your system. It could be a CVS, CNS, renal system, GIT, and even your cordoregulation syndrome. Everything happens in a diabetic embryopathy. That's the reason why the diabetes has to be screened at first trimester itself, not waiting till 20th week. And yeah, most of your embryopathy is because of your pre-gestational diabetes mellitus, whereas your GDM most likely go for all other complications that happen during delivery or I birth as child, it can be happen. Okay, so what test you go for? What type of test you do in OGC?
Oral glucose challenge test, we give 50 ml, no, 50 grams of glucose in
No, okay, 50 gram or 75.
75 grams.
We do have one step test. Initially, according to Foxy and another American association, they said two step. One step you do, if that shows the higher value, then go for the 75 gram. But in India, we have more populous state, a more populous country, and we have more mothers. We cannot go and wait for two steps. Two step. That's why we go for a directly one step where we don't ask the mother for fasting. This is very important. There is no need for a fasting value. We don't ask the overnight fasting in the mother because it's not advisable. So directly we give a 75 gram of anhydrous glucose that is mixed with how much amount of water? 100 ml of water. Sometimes this could be this anhydrous glucose can cause vomiting sensation in mother. That's why always we mix with the lime water and then we give, and you have a value, single value. Which value you take, 1 hour or 2 hours?
1 hour, 30 minutes, 1 hour, and 2 hours we take normally. Three
Okay.
readings.
Okay. So what is the value? Do you know that? What are the value which
Uh,
indicate that? Hmm.
Less than
Yeah.
140 is normal. 140 to
Okay.
199 can be it can be GDM, and more than
Mhm.
200 can be a reason for pre-gestational diabetes.
Okay. No, we can say the glucose intolerance. We can say glucose intolerance, then we go for the medium. Okay. So what is the indication? Why I am asking this is the particular to a C picture.
It can cause pre-gestational diabetes can cause sacral agenesis. So any
Okay.
neural
Mm-hmm.
tube defects can also
That's
be part of
okay.
it.
Mm-hmm. Very good.
And any
What about the gestational diabetes mellitus? Uncontrolled gestational diabetes mellitus will lead to what kind of baby?
macrosomia.
Very good. Macrosomia, definition of macrosomia?
More than 4.5 kgs at birth can be.
Mm-hmm. Very good. Or 90th percentile according to the fetal growth chart. Okay.
Mm.
So what now I already said during the birth age, extreme of birth weight. Either it's a low for gestational, for small for gestational age or low birth weight or macrosomic baby. both are predictor for the cerebral palsy. In macrosomia, it's about more than 4 kg, and this macrosomic child, while going for a normal vaginal delivery, are prone for what are the following conditions?
Macrosomia baby can there can be Erb's palsy because of
Very
excess
good.
fat
Mhm.
deposition in the neck and in the shoulders.
So,
And
why does an herb palsy occur? What is the reason for herb palsy in this case?
shoulder dystocia can be a reason.
Very good. Okay, what is shoulder dystocia?
Shoulder dystocia is when the mother has uncontrolled diabetes mellitus.
Very good.
There's hyperglycemia. The mother is hyperglycemic, so this will also
Mhm.
reflect in the fetus because glucose travels to the placenta. There's a fetal
Mhm.
hyperglycemia as well. Because of
Very
hyperglycemia
good.
in the fetus, there is hyperinsulinemia, and
Mhm.
insulin causes fat deposition that in the shoulder and in the neck, which causes
Mhm.
shoulder dystocia, and during delivery it results in Erb's palsy.
Very good. Shoulder dystocia is when the anterior shoulders are about to deliver, the delay in the delivery of the anterior shoulder. This is a very important question. Like this is an important point in OG they will ask. It's one of the OG question. When do you define shoulder dystocia? This is the anterior shoulder. That if it comes delay, when the delay in the delivery of the anterior shoulder is not known to be said as the shoulder dystocia. Yeah, this shoulder dystocia, because of the shoulder dystocia, that's a delay in the delivery. And second point is they are more prone for the birth asphyxia, in utero hypoxia as well as the birth asphyxia. And this birth asphyxia is indirectly, it will directly cause your cerebral palsy.
Cerebral
That is one
palsy.
of the reasons. Yeah, that's the reason why I asked this question. What is the importance of relevance of GDM, macrosomia, and cerebral palsy? Okay, then no history of headache, blurring vision, and period edema that suggestive of your preeclampsia,
Preeclampsia.
imminent eclampsia, or eggs. Now, this preeclampsia will lead to what kind of baby? If it's an uncontrolled hypertension and you are not controlling it with medication, what kind of baby will happen in this mother?
Like in GDM, we saw macrosomia. In this, there can be premature,
Yeah,
like they can be
prematurity.
premature.
Very good. Now, what? Now, tell me how prematurity is related with CP.
Prematurity can result in the lungs not being developed properly, which can cause hypoxia,
Mm-hmm.
which can cause
Mm-hmm.
brain like developmental delays due to the impaction on the brain.
Very good. Another reason is yeah, RDS is one of the most common for premature. Apart from that, what could be happen during this delivery of this preterm child to a normal delivery?
Any infections can from the reproductive tract can also cause.
No, yeah, it could be sepsis. Yeah, neonatal sepsis can go for meningitis, and the meningitis can, as a sequely, the child may go for CQ. Okay, but that's one of the reason.
And
Another reason.
other prematurity, there is complications such as intraventricular hemorrhage, necrotizing
Very
enterocolitis
good.
also.
Exactly. Very good. Very good. IVH. How the IVH is related to CP here?
Intraventricular hemorrhage causes increased intracranial tension, which can
Okay.
and which can also cause decreased blood supply to the brain, and
Mm-hmm.
so the brain is deprived of oxygen, which can also lead to brain insults, can lead to cerebral palsy.
Yeah, this could be one of the reason, but intraventricular hemorrhage and preterm baby are more prone for birth asphyxia. So IVH, preterm plus birth asphyxia is because the IVH is because of germinal matrix hemorrhage. This germinal matrix, when you see the ependymal lining of the third ventricle, behind your not behind, below the ependyma, you have this germinal matrix. It's a rich vascularized structure, and this is the reason where all your glial cell and immature oligodendrocytes are present. Okay, when this germinal matrix get hemorrhage because they are friable capillaries are present, and because of shear stress, because of birth asphyxia, because of preterm delivery, these are more friable and they get into there will be a hemorrhage, and because of this hemorrhage, the germinal matrix cells, your glial cell and oligodendrocytes, which has to give up to the neurons, will get the problem. They get damaged, and this leads to a condition known as periventricular leukomalacia. this periventricular leukomalacia is the one of the reason for the CP in your
Spastic
preterm child.
hemiplegic. Yeah.
What type?
Spastic
What is
hemiplegic
it?
palsy.
No,
The
no, no, no.
spastic diplegic palsy actually.
Yeah, spastic diplegic palsy is commonly seen in preterm due to periventricular leukomalacia. One of the reasons for periventricular leukomalacia in preterm is a combination of prematurity with intraventricular hemorrhage plus birth asphyxia. Okay, and this is the reason why this children and why that's a diplegia. What do you mean by diplegia? What is type spastic diplegia? Hmm. Your spastic CP. What are the types of spastic CP? We will discuss here itself so that we don't want to waste much time. What is spastic CP? Hello? Hello? Hey, do you listen? Hello, Madhuvita, are you listening? Hello? 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 I think, I guess, hello? Uh, I guess, okay, so before the, I guess the connection is problem with our side. So, okay. Now, okay, we will go for this. Okay, so as I asked the question, what is spastic diplegia? Spastic is CP. So we have three type of uh, spastic CP. So what are the three types of spastic CP? You will see it's one is spastic hemiplegic, spastic diplegic, and spastic quadriplegic. Right? Spastic diplegic. I guess she had joined. Hello, Madhuvita.
Yes, sir. வந்துட்டாங்க sir.
Okay, now
So
now
the
you can
connection has
finish.
stopped. Yeah. Yeah.
Okay, no problem. You can start. Okay. Now tell me about the spastic CPs. What are the types of spastic CPs? So which we will ask.
So spastic CPs, there's spastic quadriplegia, spastic diplegia, spastic hemiplegic CPs.
Okay.
In
Right.
India,
Now,
yes.
yeah. Tell. You complete it.
Okay. In India, spastic quadriplegia is the most common, and it is mostly because of perinatal asphyxia. And the common comorbidities are intellectual disabilities, pseudobulbar palsy,
Very
microcephaly,
good.
or
Very
any
good.
squint. For example, in our case, there was squint, and any visual
Okay.
disturbances can also be seen.
Very good. Okay. In spastic diplegia?
In spastic diplegia, that is the second most common, and in that mostly intellectuality is mostly preserved, but
Very good.
as sir said, there is periventricular leukomalacia in spastic
Yeah.
diplegia.
Very good.
Then the third
Then
is
third.
spastic hemiplegic palsy. It usually results from any stroke or vascular insult, and in
Very
this the
good.
common thing that is seen is early hand preference.
Very good, very good. You answered very well. See, all the points you have said is perfect. Okay. Spastic, diplegic. So, what is the preference? Like you said, spastic, hemiplegic, diplegic, and quadriplegic. How you will differentiate with the weakness, what is stiffness? Which limb stiffness is commonly seen in diplegia?
In diplegia, it's mostly spastic. We cannot say hypertonia because hypertonia comprises of spasticity, rigidity, and dystonia.
Very good. Anything, if the same patient can present with all these three features?
Yes, that is called
CP is this one?
mixed
Very good,
CP.
exactly. Mixed CP can present with spasticity, rigidity, and dystonia. Now tell me, what is difference between spasticity and rigidity?
So spasticity is basically increase in muscle tone, and it is velocity
Mhm.
dependent. And
Very good.
spasticity, there is a lesion in the pyramidal tract, and only
Very
one
good.
group of muscle is involved in spasticity.
Very good. Very good. What about rigidity?
Rigidity is mostly an extrapyramidal cause. There's basal ganglia
Mm-hmm.
involvement, and
Mm-hmm.
in spasticity, we saw there is only one group of muscle involved. But in rigidity, both agonist and antagonist muscles will be involved.
Very good. Then about dystonia?
Dystonia, there is a sustained and repetitive muscle contractions, and there
Mm-hmm.
can be abnormal postures in dystonia as well.
Yes, very good. Good.
And
You are.
dystonia is not velocity dependent like spasticity.
Okay, so spasticity, rigidity, and dystonia. Now, when you
Yes,
go
sir.
for the spastic diplegia, you said which limb is more affected, whether it's upper limb or lower limb.
So just 1 minute.
Yeah, very
Yeah.
good. Yeah, you
So
give a
over
good
here,
picture. Mm-hmm.
Over here we have this is for pyramidal involuntary, that is for the cerebral cortex. So we have
Mm-hmm.
spasticity hemiplegia will be one side is affected, both your upper limb and your lower limb. And for
Cool.
spastic diplegia, that is also called as paraplegia, there will be more
Mm-hmm.
involvement of the lower limb and the upper limb is partially affected.
Mm-hmm.
In quadriplegia, all four of your limbs are affected.
Very good. Exactly, you said. So, as concise, when you say spastic diplegia, your lower limb is more affected than the upper limb. In quadriplegia, all the four limbs are affected. And in hemiplegia, it's only one side of the limb, upper limb and lower limb of one side is affected. Right. Now, you
Yes.
tell me in spastic diplegia, which is the most earliest sign you will see in a diplegia, spastic diplegia?
In this, it's linked to prematurity, and there's no intellectual causes.
Very
In
good. Yeah.
spastic diplegia, we can see
Very good.
tremors. We can see in spastic
No, ma.
diplegia.
Tremors will adilla. Next, anything
Okay.
which is the earliest sign.
Um, I'm not
Hmm.
really sure, sir.
The earliest sign is see, you have given all the thing here. One of the thing you should see is in passive diplegia, you see a sign called as commando crawl. In diplegia, you know crawling and creeping. What is the difference between crawling and creeping?
Crawling is it uses more of muscle coordination than creeping. Creeping is along with the floor as such, but I'm not really sure of the proper definition.
Crawl, simple. Crawling and creeping. Crawling has A in it. So the child will move all his limb along with abdomen. Abdomen will be on the ground, and the child will move. It will it's for a locomotion. So crawling with the abdomen in the ground, the child will move from one place to another. In creeping, it doesn't have A, so that the child will use his both and foot to with the knee on the ground and abdomen above the ground to move from here. Crawling occurs at the age of 8 months and creeping at the occurs at 10 months. Now, in this child, since the child lower limb is more affected than the upper limb, the child lower limb is not well developed and there's a stiffness. So the child cannot move the lower limb as such compared to the upper limb. So now the child will, with the help of upper limb, the child move from that place, but he will drag or he or she will drag the lower limb along with it. This is known as commando crawl. You have seen this commando who practice during the training while they go below the fence. They will below the fence in that mud. They will be crawling like this. This is known as commando crawl. So commando crawl is the earliest sign you will see in the spastic diplegia. And what other thing you will see? You in this picture you see this that's a scissoring. What is the known of scissoring? Why the scissoring is happening here?
The legs cross each other when they are walking. So
Yeah. What is due to the reason for scissoring in spastic diplegic CP?
The hip adductors are have a
Yes,
high
yes.
tone. Yeah,
Yes,
have a yeah.
hypertonic. Yeah, you are right. It's a spasm of your adductor muscle. The child will have a scissoring gait, and as you say, one of your point is clinically the mother, the child resists the changing of diaper. Changing of diaper will be very difficult because of the spasm. The child will not open up his legs. As a result, the mother feel very difficult to change his diaper or change his clothes. Okay. Now,
Yes.
okay, this is one of the reason. And in hemiplegia, you as you said early underness. Early underness because already one side of the muscles, one side of the body is weak because of the hemiplegia. So automatically the child will use the normal limb, normal side. That's the reason they have an early underness. And what a quadriplegia? Quadriplegia and this we say diplegia. In quadriplegia, IQ is always low and they have more
Mm.
common seizure. Whereas in diplegia, IQ is normal, as you said, and the seizure risk is very rare in diplegia compared to quadriplegia. And it's a spastic quadriplegia has a poor prognosis in case of morbidity. Whereas spastic diplegia, since their IQ is normal, seizure, they are very rare, seizure occurrence is very rare. If they have been supported very well by the family and had a good physiotherapy and other therapy, they have a normal life except for the spasm in the lower limb, which can be corrected with physiotherapy, occupational therapy, and surgery for the contraction whichever develop, they can lead a normal life. Whereas in case of quadriplegia, they have more cognitive defects. They have more IQ less. They have more recurrence of seizure. And feeding difficulty is more commonly seen in your quadriplegia rather than diplegia. What is the cause of feeding difficulty in a CP child? Why
Feeding
eating?
difficulty. Yes, sir.
Yeah. Yeah, you tell.
Feeding difficulty can be because of pseudobulbar palsy.
Very good. Apart from that, that is one of the reasons. Supranuclear pseudobulbar palsy is one of the reason. Another thing in CP, it is a motor area of cortical area is affected, and this motor cortical area is also involved for your coordination. When motor coordination is not occurring, there will be a muscles will not coordinate among itself. As a result, the child may have this feeding difficulty. This is more common in this quadriplegia rather than diplegia, right? Okay. Okay, we can go for with the history. We have right
So we'll move on to the
now.
developmental history.
Yeah, you can go for it. Wait. You in this case, you go for the postnatal history. I have to ask this question. I guess you may. Yeah. Third trimester we completed, right?
Yes, sir.
Yeah. Okay, you
Oh
said
no,
no, we didn't complete it. No, okay,
no.
this more of the more history. Is your bike accident in ninth month? As some correlation, I guess there is less correlation unless the child may go for intracranial hemorrhage, the child may go for DDM. Okay, if this bike accident was severe enough and if the fetus has an intracranial hemorrhage, more likely a subdural hemorrhage, other kind of hemorrhage, where if it is insult is seen, because this is also very important. If it is seen and you go for a preterm delivery, that may be one of the reason for DDM. Less likely, which I am just giving a speculation. Okay. In natal history, you said it's a full term LUCS, non-progression of flavor, and you said you very well explained about what is NPL as per the definition for primary and second gravida. Baby did not cry at birth. Now you define me what is birth asphyxia.
Birth asphyxia is when there's lack of oxygen and blood flow to the brain. So it depends on how
Mm-hmm.
long the infant was deprived of oxygen and the
Mm-hmm.
SpO2 and how quickly the treatment is started.
Okay, now what is the four factors that is should be satisfied before labeling the child as birth asphyxia? What are the four factors? Do you know that?
I'm not sure, sir.
Okay. Birth asphyxia is defined when the fetal cord blood pH is less than 7.21 at the time of birth. First point. Second point is when the Apgar score is less than 5 or 3, not less than 3 at 5 minutes. Third point, if there is any neurological sequelae like ICH or seizure. Fourth one is multi-organ dysfunction. When any two of the following satisfy this, then you go for the termination of birth asphyxia. Okay, but for our convenience, we have mild, moderate, severe birth asphyxia. Mild birth asphyxia money at 1 minute, 1 full minute, if the Apgar score is less than 7. In moderate birth asphyxia, when the Apgar score is 4 to 6 and the child having a slow gasping breathing. And in severe birth asphyxia, the Apgar score is less than 3 and there is no breathing effect at all. So according to this, we classify it as mild, moderate, severe birth asphyxia. Okay. Now in this case, the birth asphyxia, you said it did not cried at birth and the child has 2.5 kg and the NRP, that is the neonatal resuscitation program, went till your intubation, right? The child was
Yes, sir.
intubated and admitted in NICU. The child had a history of seizure during the admission. So this itself tells the child has an HIE classification 2, grade 2, because in grade 1, a seizure is less common, and grade 3, there is no seizure because completely the brain has gone to comatose stage and there is no exitatory phase for the brain in HIE3, and the seizure is more common in HIE2. So the child has undergone from birth asphyxia, the child had an hypoxic ischemic encephalopathy and it was graded as 2 because the child had a seizure episode, multiple episodes of seizure. Now, the point is which is opposing your fact is you go for that postnatal history. You go for postnatal. Yeah, you say
Yes.
the child was intubated, right?
Yes.
Intubated in labor room and shifted to NICU at birth. And you already also said that breastfeeding should started after 2 hours of delivery, which is contradictory. The child was
Mm.
intubated, so this is contradictory. Okay, I guess
Mm.
it was wrongly taken by you, or the mother has given a wrong detail because after the child has started shifted to NICU after the delivery room, and within 2 hours the child would have that is impossible for the child for going for breastfeeding for an intubated child, right?
Mm.
So the
Yes, sir.
child it was just this is which is contradictory to the fact. So this tells that significantly the child has suffered birth asphyxia and also suffered HIE, hypoxic ischemic encephalopathy. Now tell me, you also asked about neonatal jaundice. What is the relation of neonatal jaundice in cerebral palsy?
Neonatal jaundice can cause kernicterus, which can affect the basal ganglia.
Okay, what type of CP it does causes?
It can cause dyskinetic or extrapyramidal palsy.
Very good. Extrapyramidal palsy. Now, okay, in birth asphyxia, you also can birth asphyxia can cause dyskinetic or chorioauditoid CP?
I'm not sure, sir.
See, both birth asphyxia and kernicterus can cause dyskinetic or extrapyramidal CP. In birth asphyxia, the lesion is in putamen, okay, and
Mm.
putamen and ventrolateral part of thalamus, and this lead to a condition called as status marmorosus. Status marmorosus, and this will go for a dyskinetic CP in birth asphyxia. Whereas in kernicterus, the deposition of unconjugated free bilirubin in globus pallidus and hippocampus will lead to this kinetic CP. So in both the way CP is seen, this kinetic CP is seen, but the location of damage is different. Whereas in birth asphyxia, it's your putamen, whereas in kernicterus, it's your globus pallidus, right? Okay.
Yes.
Now this is over. And now you said the breastfeeding was continued till 6 months of age. Now this thing is, the child had any feeding difficulty while the breastfeeding? I had mother notice any feeding difficulty?
The mother said there wasn't any proper latching, but with time it
Mm-hmm.
was fine. But
Okay.
other than that,
Mm.
the feeding was okay. The child was able to swallow the feed.
Okay, so point is that the feeding problem was not there. And 7th month, the feeding was started. And the child was able to eat the weaning food, complementary feeds.
Yes, yes, sir.
Okay, now you continue with the developmental history.
Uh, So, developmental history, gross motor development history, neck holding was attained at 11 months, rolling
Mm-hmm.
over was attained at 1 year. He sits with support at 3.5 years of age, and sits without support. We weren't able to elicit the history. Stands with support at 3.5 years, and stands without support is not attained yet. So, the developmental age is 9 months.
Okay, what is developmental quotient? Actually, the DQ for this is 9 month money. What you 9 month is equal to 1 year. You say it's 1 year,
Yes.
approximately 1 year for each. And now the age of chronological age is 4 years, right?
Oh,
1 by
yes. Yes.
4 is 20. It's 25%.
Yes.
That's a significant developmental delay in the gross motor. What is a significant delay? Less than 70%. Okay.
Mm.
Whenever there's a less than 70% of developmental age quotient, then it more probably a significant delay, and the child has a gross motor, significant gross motor delay. Okay. Now tell me about the fine motor.
Fine motor, immature pincer grasp was attained at 1 year. Mature pincer
Mm-hmm.
grasp is not attained yet. So the
So it
developmental
is
age is
also
9 months. It's
so it is
also
developmental
25%.
quotient person. So which
25.
has it's also significant delay in the fine motor, right? Okay.
Yes.
Tell about the language.
Language cooing is attained at 1 year. Babbling is attained at
Mm-hmm.
2 years. Monosyllables
Mm-hmm.
attained at 2 to 2.5 years. And
Mm-hmm.
bisyllables attained at 3 years.
So 3 years. Okay. So this is also 25%. So language is also
25%.
significantly affected here. Okay, right.
Uh,
Nice.
social
There.
and social and adaptive. Social
Mm-hmm.
smile is attained at 1 year, and he recognizes
Mm-hmm.
his mother at 1 year. He
Mm-hmm.
recognizes strangers at 2 years, and he plays with balloon at 2 years. So the
Okay.
developmental age is also same here, 25%.
So
The
all at
quotient.
25%. So very good. So developmental quotient in everything is 25%. All areas are significantly delayed. So most likely, if it was a spastic diplegic case, your language and social adaptation is less commonly affected. Whereas in quadriplegia, which is poor prognosis, and all the domains maybe get equally affected. So this is one of the point which favors for quadriplegia. And because in quadriplegia, as I said, it's one of the severe poor prognostic area and where all the domains are equally affected. Whereas in diplegia, your IQ is normal. Even a child has vision more or less normal. Learning disability will be present. But apart from that, the social and adaptive as well as the language is somewhat preserved when compared to the quadriplegic. In quadriplegia, everything is equally affected. So in this case, also, it has been equally affected. It is one of the point which pointing toward the spastic quadriplegia. We cannot tell with this history, but when you go another thing you should see it whether it's a progressive error, uh, whether it's a progressive versus static developmental delay. Why this is important? Because something like if social smile for 2 months, it is acquired in 1 year. Okay, so you just calculate this year, 2 months by 1 year. So it gives some value of DQ. And same DQ is acquired for the recognizing mother. 3 months, 1 year, somewhat is equal to 1 year. So whenever the DQ is relevant, similar in both 2 to 3 domains, then it's more likely a static thing. Whereas if DQ is changing with every social milestone, with every milestone, the DQ is changing. One is compared for initially the DQ was good. Now it's the same. Another milestone takes more time to appear. Another milestone takes another more time to appear. When the DQ is changing for each milestone, developmental quotient, then it this is different. It tells that it's progressive in nature, and that separates it from the static encephalopathic. Now, Mane, what I mean to say is if the DQ, developmental quotient changing in each field domain for fine motor itself from one milestone to another milestone, if the DQ is changing from one to another milestone in significant way, it tells about the progressive nature of the neurodevelopmental problem. So that unfavors CP. CP is always a static problem where your developmental quotient remains static. In this case, it's a DQ is static, so it also favors your CP. Okay, then okay, can go for it.
Sir, I have a doubt here.
Yeah.
After we calculate the developmental age and the developmental quotient, since he's a
Mhm.
4-year-old child, do we calculate
Mhm.
the IQ with the Wechsler preschool and primary scale of intelligence?
So okay, you can go for yeah, IQ can be pressured, but IQ per se for exam is not required. Okay, you can go with in a normal routine checkup. Yeah, that is very important. You have to go for that developmental scale assessment also. We are just for examination purpose. We are going to developmental question and age. It is simple because it's just calculative by the mathematics like chronological development. But IQ has to be checked. It has a clear cut chart and it has to be done by a well trained psychologist or psychiatrist, right? So you cannot do while during a normal your university exam. It has to be done separately in a well um, structured manner. So it cannot be done in laziness. It has to be in a well-structured manner. It has to be done according to the protocols. So yeah, you can do that IQ test. IQ testing is done only in a psychiatrist and well-trained psychologist and psychiatrist will do this IQ testing.
Yes, sir.
Yeah.
The significance behind taking the developmental history is because CP children are more prone to developing ADHD and autism, and
Very good.
in less than 6 years of age, we can
Mhm.
use the Trivandrum development scale to assess development. Uh,
Yes, good.
in CP children, because they do not go out more often, there's decreased sunlight exposure and decreased vitamin
Mhm.
D. So they're
Mhm.
more prone to fracture. So we need to ask a history of fracture in the CP patient as well.
Very good. Very good. Nice. Nice. Cool.
And global developmental delay is
Yes.
known as delay in developmental milestone in more than two domains, and this
Mhm.
term global developmental delay is used in less than 5 years of age. If the child is more than 5 years of age, we use the term intellectual disability.
Very good, right. So you have given the development and the GDT. So this child is having global development delay because all the four
Yes.
domains have been affected. Okay, next. You can go for the next
And
system.
okay.
Bol.
And
Yeah,
when
yeah, yeah,
checking
tell.
for development and when checking for developmental history, are supposed to rule out vision and hearing should also be tested, because they can also
Hmm.
be delaying in development because of their vision or hearing as well.
Very good. Yeah, this is also one of the important feature because when you are selling that's a delay in the language and language milestone, always assess your hearing because in some time when the hearing auditory neuropathy, when auditory neuropathy, you say when your outer acoustic emission OAE, which we've done with the outer air cell in your ear, it's normal compared to your BERA, which is brain stem evoked potential test where it's abnormal. When there is two dissimilarity. When the OA is normal but beta is abnormal, it's significant that there is a sensory neural hearing loss. That is an auditory pathway abnormality. This mostly seen in your kernicterus. And this kernicterus is one of the cause for your dyskinetic CP. So hearing assessment and vision assessment is equally important in any CP or any neurodevelopmental case, which you cannot perform, but in during your examination part or in your management parts, you have to say that I would prefer to also follow up with the hearing and vision problem because they are one of the most common comorbidities associated with any CP child. Okay? Okay.
So the child is put in a special school, and
Mm-hmm.
physiotherapy is started for the child.
Okay,
The
done.
child needs assistance for doing daily activities like dressing, bathing, and tying shoelaces. This is
Mm-hmm.
important to elicit in the developmental history, because we need to know what the child can independently do and what the child needs assistance with.
Very good. Next.
So, coming to past history, there is history of
Mm.
seizures, as mentioned before. For 1.5 years, there is no post-seizure weakness. There is history suggestive of head injury in the antenatal period because of the bike accident, but it is not a sure possibility. There is no history
Mm-hmm.
of surgery, no history of, and there is history of consultation and regular follow-up in Egmore Children's Hospital.
Okay.
Physiotherapy is started since third month of birth.
Okay. Right. Mm. Okay. Then
Moving on to family history, there is no history of similar illness in the family. He's the only
what is the
affected child.
important? Okay. What is the important of asking the similar illness in the family? CP can
Uh,
run in family.
CP can run in families, and as this is a third degree consanguineous marriage, autosomal recessive disorders can be transmitted to the offspring.
Cerebral palsy causes you have genetic and metabolic causes also. It's not just because of autosomal. It's not only the birth aspect here. Apart from the antenatal causes, as I said, you already ruled out in utero infection, urinary tract infection, chorioamnitis, obstetric complication, teratogenic exposure, perinatal asphyxia. Apart from that, you have also kernicterus, then sepsis, neonatal sepsis, meningitis, and intracranial IVH, and also you have prematurity, LGA, HGA, small for gestational age. There all other risk factors. Apart from that, genetic and metabolic causes could be a reason of CP and autosomal recessive condition in the third degree consanguinity. Yes, that should be us. So one of the reason why you're asking a similar illness in the family is also to rule out genetic causes and metabolic causes. Can any genetic polymorphism can lead to CP? Do you know any CP which have a genetic polymorphism that because of that the CP can occur? Any
I'm
idea?
not sure. I'm not sure actually.
So you said that's a preterm delivery, one of the cause of inflammation. That's the release of IL-6, and that can go for DDM, right? You said that during
Yes.
your
Fever
now
in third
any
trimester.
yes IL-6 polymorphism or your factor V leading polymorphism in children can lead to the thrombophilia like state, and the child may have a fetal or neonatal stroke and can go for a spastic hemiplegic sick. So any genetic polymorphism to your IL-6 or your factor V lead-in factor can lead to neonatal or fetal stroke, and that in turn causes spastic hemiplegia. Okay? Okay. No, go for personal history. Yeah.
Personal history, the child has normal sleep, normal appetite, normal bowel and
Mhm.
bladder movements. So, the significance of asking personal history in a cerebral palsy patient is to rule out, normally they present with constipation because the sphincters can be in hypertonic. And the
Mm.
other comorbidities associated with CP are behavioral abnormalities, ocular squint, UTI, or recurrent respiratory tract infections. There can also
Mhm.
be cognitive impairment. And
Okay.
here we did a diet 24 hours recall method and found out
Mhm.
that there's a calorie deficit of 648 calories and a protein deficit of 4.1 grams.
Mm. Can you tell me what is the cause of malnutrition in CP child?
Malnutrition can be because for example, in spastic quadriplegia, the child can present with pseudobulbar palsy, which can result in
Mm.
poor feeding, and there's also
Mm.
micronutrient deficiencies in cerebral palsy
Mhm.
patients, which can
Okay.
be a cause of any severe acute malnutrition.
And third thing,
Uh, the motor incoordination.
yeah, that could be reason. Another thing,
Uh,
and they are most of the CP child or neglected child, right?
okay, yes, sir.
The social factors also should be considered. They are mostly neglected child. They are not been taken care for. They are not been given the proper needs or not taken care. As a result, they can go for malnutrition. So that could be one of the important factors that has to be assessed. Okay. Okay. Then treatment is physiotherapy since 3 months of age.
3 months of age, and the
Okay.
normal recommended duration for physiotherapy is lifelong, and it's
Mhm.
recommended to do it 3 times a day, but there is some patients present with severe pain because of the spasticity while doing physiotherapy.
So spasticity now physiotherapy. You said very good. What is the recommendation of physiotherapy to prevent contractures? Because contracture is a long-term complication of any CP. And you said
Yes, sir.
every day the child has to do it 3 times a day, and that principle is one joint above and one joint below should be there. Minimum 10 minutes has to be done, and full range of movement has to be done. If this is done in the proper way, then only the physiotherapy will be successful. And the point is for which type of problem, for which type of yeah, yeah, I will wait a minute. Which for which type of contracture you will do this physiotherapy? Like
Uh,
which is a dynamic problem or a static problem?
for a static problem, we can do. No, actually, for a dynamic problem, there'll be improvement with physiotherapy. So,
Exactly. In a dynamic problem, if you do any static problem, it's already contracture has been occurred, and this contracture is not even moving. Here we cannot do any physiotherapy because there's no scope of physiotherapy in a static problem because it's already contracted and there is no movement at all. But in a dynamic, there's some range of movement which you can increase by doing this regular physiotherapy. And for static contraction, it's the only surgical correction is needed. Okay,
Yes, sir.
right. Now you can go for the environmental history is I think that's no significant. You can skip that for the time being. For
Yeah.
time being.
Yes, sir.
Then general examination, you can go for general exam.
Yeah, there's no contact with TB patients as well. General examination, the child is alert, active, playful, good hydration, and he's afebrile. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema is not present. Coming to
Okay.
vitals, the pulse rate is 110 per minute, and the rate, rhythm, character, volume, and the radiofemoral delay must be seen, and all the peripheral pulses were felt. Respiratory rate is 24 per minute and thoraco-abdominal type. BP is 80 bar 50 millimeters of mercury and recorded in the right upper limb in supine position. The oxygen saturation is 98% in room air.
Oh, cool. Okay. Then tell about that. I think vitals are within normal limit, right?
With the normal,
Okay.
yes, sir.
Now the important concept is anthropometric. Now tell me about the anthropometry.
Anthropometry, the weight is 12 kg and height is 94. Significant in anthropometry is the head circumference, that is 46 centimeter, and mid-arm
Mm-hmm.
circumference, that is 13 centimeters. So in SAM classification according to WHO, 13 will be mild severe mild malnutrition, and head
Mm-hmm.
circumference is 46, which suggests microcephaly.
Okay. For this age, 4 years, 46 centimeter is less, right?
Less.
So microcephaly, one of the important factors for the diagnosing CP, microcephaly is one of the important components. Even enlarging it or a normal its size in a suspected CP child, you have to go for an alternate diagnosis. This is one of the big things. Whenever you see a CP child, if you're suspecting a CP in a neurodevelopmental delayed child, and that its circumference is near normal or it's enlarging macrocephaly, then CP is unlikely. And here it's microcephaly, so it's also one of the important factor to tell the child is having CP. Okay, right. Then
The differential for microcephaly is
hmm,
craniosynostosis.
okay.
Microcephaly, so how do we differentiate is that microcephaly normally presents with developmental delay, and in craniosynostosis, there's ridging of the sutures and there is an
Mm-hmm.
abnormal shape of the head.
Very good. Cool. So you have a many syndrome, which is for time we cannot discuss about the syndrome like Apert syndrome, Carpenter syndrome, right? So we
Yes,
have
sir.
many syndrome with craniosynostosis. Okay, cool. Well, tell me about the head-to-toe examination. Any quickly relevance finding you tell? We don't have much time. So
Yes, sir. Relevant finding in head to toe examination, head lag is positive, eyes
mm-hmm.
squint is positive, but we are not sure if it's a divergent or convergent squint. We weren't able to
Okay.
see that. Then
Okay.
there's no dysmorphic faces or no external neurocutaneous markers.
Very good. Why this important of dysmorphic phase and external cutaneous marker in a CP child?
There can be neural tube defects such as spina bifida or any anencephaly, or neurocutaneous markers
See,
can.
wait. No. Point is, you don't tell a neural tube defect on the second thing you say anencephaly because anencephaly child will never survive till 4 years, right? So
Okay,
never,
yes, sir.
never tell the anencephaly. Yeah, neural tube defect you can tell partially correct. Neurocutaneous syndromes like your tuberculosis, neurofibromatosis. Now, point is when you're suspecting any genetic and metabolic cause like Gotchers, right?
Mm,
Gotchers, Niemann Pick or Tay Sachs, neurometabolic disorders, Alexander syndrome.
mm.
You see
Yes,
meta leukodystrophy, right? When
yes,
you are
sir.
suspecting that, there you have to see this one coarse faces or any neurocutaneous marker to rule out the genetic causes or metabolic causes of the CP or neurodevelopmental delay in the child. For that, I am asking this is right. Okay,
Yes, sir.
cool. And
There's no cafe warts and there's no
mm,
tuft of hair, so that can also be
very
neurocutaneous
good.
markers. Then
Okay.
moving on to examination,
So wait
posture
a minute. You have undescended testes, right?
testis. Yes, yes, sir.
Undescended testes. For that, the child what treatment the child is getting?
The testosterone can be supplemented, but we can also wait and watch. So in this child,
No, point is the point is the age of the child is
4 years, so testosterone has to be supplemented.
no 4 years. So the child
Four
has
years.
nearly 4 years, and for 4 years the test is not distended. So what is the risk factor for the child?
Um it can go for like sterility or
One thing is sterility. Another major risk factor is what?
mm, not sure, sir.
The child will go for malignancy, right?
Yes, sir.
Intra-abdominal testis has a higher risk for what type of cancer?
Uh, not sure, sir.
You have to see. Okay, you well see. I
Okay.
know. But you should. This is very significant because undescended test is still 4 years, and the parents are not getting any treatment. It's just, I guess, kind of astonishing point. I think either the child has not been the examination was done not properly because undescended testis at the age of 4 years is one of the very risk factors. So we have to rule out where is the testis is there because high risk of malignancy is also present in this case. Another
Okay, sir.
thing why I'm asking on undescended testis, we have to also some in case of metabolic disorders or another disorders, we have to rule out any other thing kind of thing. Okay then.
Yes. Then going on to examination, it's performed with the
Very.
child sitting on the bed, and gait,
Mhm.
because the child is spastic and not cooperative, it's not observed.
Okay, what type of gait you will see in spastic hemiplegic?
We can see scissoring gait.
Very good. Or scissoring gait? No, scissoring gait is not seen in spastic hemiplegic because hemiplegic, that is one side of your leg and arm is not working, right?
Yes, sir.
So scissoring gait is seen in diplegic.
Diplegic. Okay.
Okay, what type of gait is seen in say, spastic hemiplegic? What is the common in a medicine case hemiplegia? What is the common gait you will see?
Uh,
You know the answer. You
the
can tell it. What gait is seen in hemiplegia in a CNS case of medicine?
not sure, sir.
Circumduction gait.
Circumduction gait. Yes, sir. Okay.
Circumduction gait is seen in spastic hemiplegic way. Spastic diplegic, you see what you see a scissoring gait. Okay, and
Yeah.
ataxic gait, what type of gait you will see? Ataxic hemiplegia. You have an ataxic CP also because of cerebral lesion,
Yes, sir.
right? Where what that the eye stepping gait.
High stepping. Okay.
Gait, right? So these are
Yeah.
the gait abnormally seen in CP, right? Okay, CNS examination. You said.
So the higher functions, the child is conscious, well oriented to time, place, and person. Memory, immediate, remote, and recent memory is intact. Abstract relation is normal.
Point. Wait a minute. Since here you be very conscious. One thing, the child is babbling, right? The
Yes,
child
sir.
is what the language milestone the child has attained?
The child has attained babbling only.
Only babbling. So in
Yes.
this way, how you will say the child is oriented to time, place, and person?
Like he was repeating random words, but it wasn't properly articulated. So we just
No,
assume that
see,
he.
don't assume anything. Okay, but the point is at the 4 years because history is very important. When always examiners will see whether your history and examination are relevant. Even you can even because babbling child you cannot examine the orientation. To be honest, you
Hmm.
cannot orient a child by with the help of the babbling. You cannot assume. Okay,
Hmm.
you are presenting very well. That's why I'm telling. Never since you are presenting very well. These are the point you have to. This minute points it will has to be taken care of. The
Yes.
child is only attained babbling which is incomprehensible by anyone. Even the parents cannot comprehend what he want to tell, what he want with that babbling sound. So in
Hmm.
that way, you cannot assume the orientation to time, place, and person. Better you can say it cannot be performed because the child is non-cooperative. The child is has the only incomprehensible sound with which it cannot be comprehended whether the child is oriented to night. A consciousness you can tell that's okay, but oriented to time and place, okay. Memory, I think it's completely cannot tell because of
Hmm.
babbling. I can this completely the higher motor function. You can only say the bacha is conscious and Memory, yeah, with wording, articulation, you can tell about articulation. How is speech intelligence? You cannot say anything. Right-handedness. The child is having right-handed. His preference is right hand. Okay, okay.
Okay.
Behavior. Okay, but this abstract relation is so normal. Also, you cannot comprehend
You
with
cannot
the
say.
babbling.
Hmm.
Yeah, better avoid it. It
Okay.
doesn't mean that you have to. It doesn't mean that you have to say everything in the CNS examination. When you cannot perform something, because the child condition is like that. The child has only attained babbling. With that, you cannot comprehend of the orientation of the to time, place, person. The memory you cannot comprehend because the child will not repeat. Repetition you cannot see. With that babbling, what you can see, you can say whether the articulation is perfect, the way the words are being delivered by the child, you can say
Hmm.
abstraction and memory cannot be performed in the child because of the so and so you can reason it out. The
Yes.
examiner will not give any penalty for that. They will be very happy when you say this, right?
Okay.
Okay,
Yes.
then.
So
Okay.
cranial nerve examination.
Mm-hmm.
So this also like the actually when we were performing this, the mother was actually helping us interpret what the
Mm-hmm.
child was babbling. That's how we also uh, wrote the higher functions also. So, but now that we know, we're not supposed to write it. But basically, the history in higher functions is like what the mother interpreted the child was saying.
Okay.
Yes.
Even if the I don't know about your professors. What about your professor? You already presented this case to your in your college,
Yes.
right?
Yes, sir.
At that time, the sir didn't told anything about professors.
We had examined with the professor and the patient by the side. So when the child was
Okay.
babbling, the mother knew what the child wanted. So that's how
Mm-hmm.
the interpretation was happening. That's yeah.
If that's so, you can guess, you can tell it. But I guess you can tell that way also. But in the way which if the examiner is has not seen the case, has not been in the examination part, okay, then better avoid it, or you can explain that mother was helping while telling. You can go with that also. If you have a reason to explain, reason to tell that because of this only I told it, you can go ahead. Okay, then okay.
Yes,
You
sir.
will tell me about the cranial nerves. Yeah.
Okay, so the first cranial nerve, olfactory, smell sensation is intact. Optic, we used Snellen's chart, but then
Mm-hmm.
we did not use numbers. We used shapes like the E, like with the E chart we basically used.
Okay, cool. Then.
So we told the patient to like draw with her hand like what he was seeing. And the field
Okay.
of vision was normal. Color vision, we asked him to trace through colored threads, which he was able to do. Pupillary reflex also is present. That and oculomotor, trochlear, and abducens was also checked. So this can be
Mm-hmm.
remembered with SO4 LR6. All the
Mm-hmm.
extraocular muscles are supplied by oculomotor, except for superior oblique supplied by the fourth nerve, and LR6, that is the lateral rectus, supplied by abducens. That's the sixth nerve.
Very good. Cool.
Then trigeminal nerve, the child is able to clench his teeth, and
Mm-hmm.
there's normal conjunctival and corneal reflex, and there's no abnormal
Mm-hmm.
sensation over the face.
Okay.
Facial nerve, we tried imitating what he was supposed to do, and he just imitated us. And there was
Cool.
normal wrinkling of forehead, there's normal closure of
Mm-hmm.
eyelids, there is and then there's no loss of nasolabial folds, and he was able to
Mm-hmm.
puff up his cheeks, and equal resistance was given, and he was able to hold in the air.
Mm.
Vestibulocochlear,
Oh.
there's normal hearing, no
Mm-hmm.
vertigo or nystagmus was present.
Mm-hmm.
Glossopharyngeal, taste sensation was normal in the posterior one third of the tongue, and the uvula was in the midline. Vagus
Okay.
nerve, gad reflex was intact. Spinal accessory nerve, he was able to shrug his shoulders against resistance. And
Mm.
hypoglossal nerve, he is able to protrude his tongue, and there's no tongue fibrillations.
So here your nuclear cranial nerve involvement is absent. So it is pseudo-bulbar palsy. So if any feeding intolerance, feeding problem is here, you already ruled out bulbar palsy because your 9, 10, 11 nerves, 9, 10 nerves are intact. There is no deviation of uvula or anything. So your cranial nerve involvement is absent. So if any feeding intolerance in this baby or in this child is happening, it's mainly because of your pseudo-bulbar palsy. That is
Yes.
supranuclear palsy, right? Okay,
Yes,
cool.
sir.
Then.
So And attitude of the moving on to motor system examination,
Mhm.
attitude of the
Mhm.
limbs, there's no atrophy and no fasciculation. So in
Mhm.
hypoglossal, we saw there's no tongue fibrillation. Over here, we have
Mhm.
mentioned fasciculation. The difference between
Okay.
fasciculation and fibrillation is that in fasciculation, there is contraction of the motor unit, and in fibrillation there's contraction of the individual muscle fiber. And
Okay.
fasciculation, it's seen in neuropathies, and fibrillation, it's seen in myopathies and neuropathies.
Okay, cool. Now, point is there is no wasting of muscle. Okay,
No
this
issue.
itself tells in CP if there is an atrophy. What is the cause of atrophy in a CP child? Normally, in any muscular dystrophy, you have a wasting and atrophy in a peripheral cause. Central cause is less likely. But in CP, what is the cause of wasting or atrophy of muscle?
Uh, because the child is spastic, it may be because of the decline in use of the muscle.
Very good, very good. Exactly. It is a disuse atrophy. Disuse atrophy leads to the condition, right? Right, good. Next,
Yes.
you can go on.
So the bulk is normal in all the limbs.
Mhm.
There's no alteration in one limb. It's all normal in the upper limb and in the lower limb. But we saw the mid-arm circumference was 13 centimeters, so there is a severe acute malnutrition.
Okay.
Tone, we don't normally, as mentioned before, we don't say hypertonia. On palpation, the right and left, the stiffness was felt, and on passive
Mm.
stretching, the spasticity was felt.
Okay, cool. Then,
The power could not be assessed because the child was not cooperative.
okay. Now tell me in cerebral palsy whether the power is affected or not.
The power is not affected in cerebral palsy.
Very good. There is no effect in cerebral palsy. But point is, as you said, it is not interpreted because the child is not cooperative. You cannot examine the way you have to examine according to the protocol you read in book because the child is not cooperative. So that's the reason the power could not. But you can assume if the child is able to walk, then the power should be more than 3. Okay,
Yes, sir.
if the child is able to pick up something from his hand, then the power is up more than 3 because he is going against the gravity. While picking up, it is going against the gravity. So everything when it do something, it's a normal day-to-day activity. When he is able to walk, when able to pick something, then more likely the power is more than 3 by 5. That itself, the power is less affected or not at all affected. Yeah, this is very important because cerebral palsy is a disorder of tone and posture.
Mm.
It's not the power. If power is involved, then always go rule out other causes like genetic, metabolic causes, muscular dystrophy. That could be also one of the reasons why the child power goes off. Okay, so power is not, so most likely the power is not affected. Okay, right. Then
Yes.
reflexes.
Reflexes, superficial reflexes, everything is normal, but abdominal and
Mm-hmm.
cremastic reflex was not elicited, and
Mm-hmm.
bulbocavernous and perianal reflex was also not elicited.
Okay, cool. Then deep reflexes.
Deep reflexes, it's 2 plus in biceps reflex, triceps, knee jerk, and
Mm-hmm.
ankle for in both the right limb and the left limb.
Okay, cool. So it is more likely not brisk. It's
Mm.
equal normal. Reflexes are
Yes, you
also
can.
normal. Okay. Now tell me
Uh,
about the. Yeah, you can tell.
yes, sir. I didn't listen to the question, sir.
Yeah, you can. Yes, go on, go on.
Oh, okay, sir. So coordination, the finger nose test was normal. Finger nose
Mm-hmm.
test was normal, but it was a little bit difficult to demonstrate it on the child because we had to perform it on our own to make the child do it. Heel shin test was
Okay.
also normal, and drawing a circle
Mhm.
with leg was also normal. And there is
Very
no
good.
involuntary movements such as chorea, athetosis, balismus, or hemibalismus.
Okay, cool. Nice. Then go on.
Sensory system examination, touch, pain, temperature, joint position was all normal. Since we're dealing with a cerebral palsy and it's mostly a spastic type, which can be a cortical sensation is very important to be checked. That is tactile localization, 2 point discrimination, and stereognosis, which were not
Mhm.
examined in this patient because he was uncooperative.
Okay, cool.
Dysdiadochokinesia, dysmetria, and dyssynergia is negative in both.
Okay, cool. Even
Uh,
meningeal signs are, yeah, tell.
uh, Going on to meningeal signs, there's no neck rigidity, Koenig sign is negative, and Brudzinski sign is also negative.
Cool. Nice. Okay, spine is also normal. So exactly everything
Fine.
is Right.
Spine and cranium
Okay.
is normal. Mostly scoliosis is seen in CP patients, so it's important to elicit that history.
Okay.
Other systems, everything is normal.
Or within
Serious S1,
normal.
S2, yes, everything is normal.
Okay. Right. Okay. You can go with the diagnosis.
So my diagnosis is a 4-year-old child, a known case of global developmental delay with history of brain asphyxia, with birth asphyxia, sorry, and seizures, is diagnosed to be a case of cerebral palsy grade 3, probably spastic quadriplegia in type, with normal immunization, microcephaly present, chronic malnutrition with bed sores present. The system to be examined is CNS, which we had done.
No, no, you don't say at a final diagnosis. No need to tell the system to be examined CNS because that has to be done after history. After
Summary.
history,
Yeah.
before examination. During the summary, you say system to be examined. So it's a
Yes, sir.
4-year-old child, a known case of GDD, has more than two domain have been affected with history of birth as with a significant birth asphyxia in the natal history and seizure during the postnatal period is diagnosed to be a case of cerebral palsy. Okay, probably spastic quadriplegia because the spasticity is seen all upper limb and lower limb in equal condition with normal immunization. Microcephaly, yes, it is with you have seen it's 46 centimeter, which is less than 3% for that particular age. Chronic malnutrition with bed sores present. Okay. So this okay. This so how would you proceed with the case?
So we move on to the investigations. So investigations in a CNS case, we do imaging, CT or MRI brain we do. And X-ray skull is done to rule out intracranial calcifications.
Mm-hmm.
EMG electromyography is done. EEG
Mm-hmm.
for electroencephalogram, and metabolic workup is also done.
So okay. So normally a CP. So always it go for with when an approach to CP child is as follows. First, see, whenever you approach a child with CP, first thing is it's always with your history. When you detail history of your intranatal post peri from your antenatal, perinatal, natal, postnatal histories, and and a meticulous physical examination will clinch the diagnosis of CP. That is one of the most important. Your examination as well as history taking is a pivotal role in the clinical diagnosis of CP. After that, you go with the investigation mostly in cerebral palsy and any neurodevelopmental case. It's neuroimaging as the one of the important role. Which neuroimaging you will go for MRI or CT? Which you will prefer, MRI or CT?
MRI can rule out, for example, in spastic diplegia, there will be periventricular leukomalacia. So we can do an MRI to confirm it.
Any brain malformation, any neuronal migration disorder, any neuronal metabolic disorder, any diseases where you have to differentiate your gray and white matter, where your brain chemical nature or the structural nature of your brain has to be assessed, always go with the MRI, right? So MRI is the investigation of choice for any neurodevelopmental delay child or any case of CP. In neuroimaging, we have a specific modality in neuroimaging of MRI known as diffuse tensor imaging. Okay, we have diffuse tensor imaging where we map the white tract. It is the latest evolution in the MRI technique as diffuse tensor imaging (DTI), where you image or you measure or you map the white matter. In spastic diplegia CP, your corticothalamic and your corticospinal and thalamocortical circuits. This both track are involved. In a normal diffuse tensor imaging, when you see, both are normal. Okay. Whereas in a spastic diplegia, as such, it's a periventricular leukomalacia where your oligodendrocytes and glial cells, which are essential for your white tract myelination and neuronal formation, is severely affected. As a result, the white tract formation is less formed in the diplegic babies. And as a result, when you do a diffuse tensor imaging in a spastic diplegic child, both the corticothalamic, corticospinal, as well as your thalamocortical tract are reduced. This is the clinching feature you will see in the MRA of a spastic diplegia CP. In case of spastic hemiplegia, you will see a infarct. It could be a chronic infarct or acute infarct. In quadriplegia, you will also see metabolic disorder. You will see some differentiation. You will have see an hyperintensity lesion. In case of kernicterus, you will see a bilateral hyperintensity in the basal ganglia, mainly in your putamen. Hyperintensity in the putamen basal ganglia area, you will see a bilateral symmetrical hyperintensity in the T2 imaging of your kernicterus. So MRA has a very important role on the investigation of choice of any neurodevelopmental delay, more for likely for your CP, right? Okay. Now you do an MRA and you have found that that's a periventricular leukomalacia. You have changes, see all the changes, and you find that it's a spastic diplegic changes. Okay, so the MRA you go with. Now I will give two conditions, which is one of the close mimics before ending the session. One thing you are in a spastic diplegic CP child, you are suspecting a spastic diplegia in this child, and now you are doing something, you are seeing the MRI, but the MRI is normal. Then what metabolic disorder you will suspect? In a spastic diplegic child, you are suspecting a CP. You are suspecting some periventricular leukomalacia or any chronic changes. You are suspecting like that, but MRI came out as normal. Now, for you, it has you suspecting some IEM, but what could be that possible IEM that may mimic spastic diplegia?
Um, I'm not sure of this, sir.
It is a urea cycle disorder known as arginase deficiency, right? This
Oh,
arginase
yes.
deficiency can mimic your spastic diplegic CP, but when you do an MRI, it's normal. In the similar way, in any spastic dyskinetic CP, in spastic dyskinetic CP or extrapyramidal CP, if you see that MRA, and then in the MRA, as I say, in case of asphyxia, you have a lesion in the caudate nucleus, putamen, whereas in case of kernicterus, it is a globus pallidus hyperintensity. But when you see a normal MRI and the child is having dystonia and you are suspecting a spastic dystonic CP, but MRI become normal. So what is the likely possible? What could be the reason?
Mm, Not sure, sir. Inborn error of metabolism. It can be differentials of CP.
Yeah, but this is not inborn error of metabolism. It is known as dopamine responsive dystonia, or is known as Segawa disease, right?
Yes.
Segawa disease or dopamine responsive dystonia may mimic spastic dyskinetic CP, and this child will respond very well with the L dopamine. And so your treatment of choice is L dopamine. So finally, we will end it with the treatment. So what are the treatment modality you will be doing? Yeah, you can.
So mostly for CP child, it's a multidisciplinary approach and physiotherapy.
Very good. Mm-hmm.
So multidisciplinary approach because we would need a child psychologist, ophthalmologist, ENT specialist, a social worker. Excuse me, and
Yeah.
also we would probably need occupational therapist as well, and
Mm-hmm.
speech therapy as well can be included. And as there is spasticity, we can classify it according to gross motor function classification system, which can be helpful for the treatment. Spasticity is normally relieved. There's generalized spasticity and localized spasticity. So in generalized spasticity can be dealt with diazepam or baclofen, and localized spasticity can be dealt with botulinum atoxin. And for
Very
some
good.
patients, tendon release or tendon lengthening procedures can also be done. So for dystonia, the patient can be given trihexyphenidyl or
Very
botulinum.
good. Very good.
Mostly drugs are not used much, but it's mostly physiotherapy and the counseling sessions. And the parents should also be counseled about this, about the KAP, that is the knowledge, attitude, and practice.
Exactly. Very good. You said very well. First, always go for parental counseling because they should know that CP is not the doom for the child, because there are many CP if you are treated early. That's the reason why there's the need of an early diagnosis of CP. The reason is the neuroplasticity, which is very important for the long-term neurodevelopmental prognosis of any child, is seen in the first 3 to 4 years of life. So if CP is diagnosed early, this in turn will help in uh, uh, the rehabilitation of the child more, so that he may lead a normal day-to-day activities. He can lead a normal life compared to the other unaffected child. That's the reason the neuroplasticity is very important, which appears, which is very more prominent during the first 4 years of life. So when you diagnose that earlier by 1 or 2 years, and go for a physiotherapy, speech therapy, occupational therapy, and coordination effect with orthopedics, eye and ear specialists, the child may go for a good uh, neurodevelopmental outcome. So that is the reason why that's an early development, early diagnosis of CP, and as you said, parental counseling has to be done very well, so that there will be good support. Because one of the good prognostic factor for CP is your good parental support or good family support. When the parental support was very well, the child will not be neglected. You will be taken care of. You will have a regular physiotherapy session, speech therapy session, and a good regular follow-up with all the specialists under the multidisciplinary team, then his outcome will be more better rather than a other child who has not been taken care of. Okay, so and as you said, drugs for both dystonia as well as spasticity you use. And what is the latest modality that has come for the dystonic CP? With this, we end the class. So can you say any latest advancement in the treatment of CP?
I'm not sure about this, sir.
You know about the DBS? DBS. What is the full form of DBS?
Deep brain stimulation.
Very good. Deep brain stimulation is a recent advancement that has been seen that it can be used in the treatment of in the modality of the treatment of your dystonic CP. That is your dyskinetic CP, where you are going to place an electrode in the two places. One is your thalamic nucleus, thalamus. Another is your globus pallidus GPA, inner globus pallidus, right? Now, this two area, the stimulation when you give in dyskinetic dynamic hypertonia, in case of dynamic hypertonia, when you stimulate this thalamus, it reduces the dynamic hypertonia in the child. Whereas opisthotonus, the ocular involvement, this ocular nystagmus, opisthotonus, other type of dystonia, when you stimulate your inner globus pallidus, inner GB, that is inner globus pallidus, this will get reduced. So with this in one, they have found that the dystonia, dynamic dystonia, opisthotonus can be reduced by giving deep brain stimulation by targeting your both thalamus and inner globus pallidus. So it is only seen in hyperkinetic CP treatment, not in other CPs. And another important point, if it is static dystonia, DBS is not effective. For a static dystonia, there is no role of deep brain stimulation, right?
Yes, sir.
So with this, we end the class. Thank to you for presenting very well in elaborative way, and you already explained too much for a CP. I guess it would have been a very wonderful session for everyone who watched it. Mm, I wish you that you present in this way. It's one of the I have seen few students and few candidates from final year students to present in this way in elaborative in a lucid manner without any struggle or without any stoppage. You are presented it very well, ma. I guess you may become a topper. So for every other subject also you present in this way, and I guess it would have been useful for everyone who was watching it. Okay, thank you so much.
Thank you, sir.
Thank you, sir.
Okay,
Thank
sure.
you so much. It was a very brief and elaborate discussion. I think this will be helping many people. Thank you so much, sir. And thank you, Madhumita, for giving us such a wonderful presentation. I was like amazed by the way you are presenting. You are like questioning yourself, and most of the answers yourself were giving.
Exactly.
Very wonderful.
Exactly.
So thank you
Exactly.
so much.
I guess all the
Sure,
students
sir.
has to get
Definitely.
really all the students should get motivated by her because the way she presented, even before I started asking, she had already answered everything. And this is the way you have to present. The way you have to practice is the way what she did. You should present in that way that what type of question the examiner can ask, what type of cross question they can ask, and so that you can be well prepared, so that you will be less questioned during your exam. The examiner should not know that you don't know about the subject. So in that way, you have to present. I hope we will have other session with you within other topics in other case, and very helpful for every other student who are watching it. I
Thank you,
guess
sir.
we can end it. Sure,
Thank
we
you,
will
sir.
end it.
Thank you so much. And if anyone wants to present a case, not just a
Yeah,
pediatrics, if you want in any subject, kindly message us so that we will be adding you to, we will be linking you with the faculties for presenting it.
sure. Okay.
Thank you,
Thank you
sir.
for this opportunity, sir.
Okay, no problem.